is the role of target intraocular pressure in management of glaucoma by Dr. Ajai Agrawal. Ajay Agrawal is there? No? Oh, sorry.
So good afternoon, everybody. So I'll be talking about the role of intraocular pressure in the management of glaucoma. This isn't moving. Okay. So as we all know that glaucoma is a chronic progressive optic neuropathy, and reducing intraocular pressure is the only clinically proven way to retard the progression of glaucoma. So before we start therapy, it is important we rule out angle closure disease, perform a detailed ONH and RNFL evaluation. Extremely important is never start therapy based on a single high IOP reading. So if you have pressures 24, 25, don't start with your timolol straight away. Record the CCT values, and as we've been taught right from the beginning, treat the patient and not just the high IOP. So remember that the normal IOP is just a statistical description of 16 plus minus 2 standard deviations, and the American Academy has a definition, the WGA, the EGS, all of them have defined glaucoma. So all of the purpose of the target IOP is just to have just enough IOP which will prevent your further glaucomatous damage. So it is a range of IOP, it is not a single value, and it has to be individualized for every patient. Some people do it for each eye as well. Some people do it for the patient as a whole. So you want to maintain a functional vision throughout the patient's lifetime. So it is also known as a safe level of IOP. So your fundamental goal is that you don't want this graph to go down so that your retinal ganglion cell loss is so much that the patient becomes blind. So you want to stabilize things. So there is a lot of evidence from clinical studies like the OHTS, which has shown that at least 20% reduction of IOP from baseline leads to lower glaucoma progression. CIGTS has also said that TRAB versus medication, so both are useful, and when you have achieved a target IOP, the progression of glaucoma is minimized. Similarly, in EMGT, although they did not set any target intraocular pressure, but they've said that for every 1 millimeter drop in IOP, there is a 10% reduction in the risk of glaucoma progression. The advanced glaucoma intervention study also set a target IOP at less than 18 millimeters, and they've also found that it has a good effect and there is minimal visual field progression at such pressures. Although currently we would like to keep the target IOPs much lower in advanced glaucoma cases. So there is staging of the glaucoma right from suspect, mild, moderate, advanced, and an easy way to do it is by the mean deviation less than 6 to 12 and more than 12 millimeters of mercury. So why do we want to establish a target IOP? So that we have functional vision throughout the lifetime of the patient. The second part is very important. There has to be a minimal effect on the quality of the life. You don't want to bombard a patient with lot of anti-glaucoma medications. You set the IOP on initial visit, review it periodically, and individualized for every patient. So you need to consider how much is the existing damage based on your assessment of the optic nerve head, your visual field defects, what is the baseline intraocular pressure, other factors like central corneal thickness and ocular and systemic comorbidities. So as a rough guide, usually for cases with advanced glaucoma, less than 12 millimeters would be recommended. So you establish your IOP based on your individual glaucoma assessment, look at the discs, the corresponding visual fields, and if there is already glaucomatous damage, you need to set lower target IOPs. Also, it is important that you appreciate at what intraocular pressures the damage is occurring in a patient, so that if damage is occurring at relatively lower IOPs, you need to decrease the IOP still more. So for tailoring therapy, it is important to look at a number of factors. For example, if you have a patient with ocular hypertension, early glaucoma, limited life expectancy, you may even observe such patients. But for moderate or advanced glaucomas, you would definitely need to have more aggressive therapy. So if the rate of progression is less, you can set higher target IOPs and vice versa. If the patient is younger, considering other factors are the same, your target IOPs will be lower because the patient has a much longer time to live. Then you need to identify other risk factors like family history of blindness from glaucoma, the other eye, high myopias, vascular risk factors, systemic risk factors. So some of these surveys have found, like for example, that African Americans are more prone to damage as compared to Caucasians. CCT is now an established risk factor, so thinner corneas, you need to be more aggressive in your therapy. And pseudo exfoliation, again it has been found that in pseudo exfoliation and ocular hypertension, the conversion rates to glaucoma are much high. But at the same time, you need to look at the quality of life issues. And then finally, how to calculate target IOP will be based on your threshold, IOP less than 21, percentage reduction from the baseline, and formula based, which could be JAMPL, CIGTS, and the modified JAMPLs. Then there are the American Academy guidelines, European Society guidelines, more or less the same. So early glaucoma, moderate and advanced glaucoma, the target IOP ranges would be different. NTG, again, the ranges would be different. So you would like to have a combination of drugs to reduce IOP, or doesn't work, for example, not achieved or progression or poor socioeconomic status, you need to consider trabeculectomy. So to summarize, the target IOP range should be dynamic, revisited at every visit and adjusted over the course of treatment. Target IOP must be individualized. You need to look at the efficacy, side effects, cost-benefit analysis, and multiple factors like how much damage has occurred, IOP at which damage is occurring, and other risk factors. So thank you for a patient hearing.
Thank you, Dr. Agrawal. You have nicely covered everything about this target pressure.
Thank you.
Any question from the audience, please?
Suppose sir, a patient is having tension after about 14,
Yeah.
and still the vision is deteriorating.
Okay.
So what should be the, in that case, what should be the target?
So if pressures are 14 and the vision is deteriorating, it has to be in the range of 10 to 12 millimeters of mercury, as is most for advanced cases of glaucoma. Although you cannot be below 10 or such, because that won't really help. But then I think surgery would be an option in that case, if your medications, maybe pressures are not getting controlled. So usually, if 3 to 4 drugs not controlled, surgery is the only option. Yeah. Thank you.
And target IOP, I think you can keep shifting also depending
Yeah.
on the progression of the
Yes,
problem.
absolutely.
It's not the first IOP
Yeah.
which you decided.
It is dynamic.
It is the same throughout the
No,
course
no,
of
no.
the
You
treatment.
need to alter
That
it.
is very
Yeah.
important.
Yeah.
Because you can't write on the file, this is the target IOP for this patient.
That is another debate actually.
Yes.
Some people say you need to write the target IOP on the file. Some people say that the patient gets very anxious if you write it down.
Exactly.
So if the IOP is higher, then he'll say, Doctor Sahab, abhi to ye itna, mera itna chahiye, zyada hai.
Exactly.
So that is again a
By
dilemma.
the time they will come inside the room, they will
Yeah.
already having anxiety that my pressure is 18 today.
Yeah.
It was supposed to be 12.
12, yeah.
So that adds to the
So corneal hysteresis definitely has a role, although CCT के कई सारे nomograms भी आए, but I think उसमें भी there is nothing really which will say कि भाई इतना आप कम कर दोगे तो exact values आ जाएंगे. But corneal hysteresis definitely plays a very important role here in your measurements.
So are you using CCT as a constant normogram?
And we do CCT in all our patients.
Normogram you use for all your patients?
We do
Or correcting
in all
that?
the patients, yeah.